Hello, everyone. If you hear you, just say hey in the chat. Let us know where you're from, what city you're from. And we'll give you a few minutes to log in here. All right. Okay. Give it one more minute. Okay. So 14. We'll see once it hits, and we'll get started. All right. Hi, Alex from Los Angeles, but from North San Francisco today. Hey. And hey, Todd. Okay. So the session on the previous stage is over with. So while they're entering in, I'll begin. 19 and 20. Okay, so hello everyone. I am Dr. Jasmine Berry. I'm one of the co-founders of Harexi Health, where I serve as the Chief Technological Officer and Artificial Intelligence Research Scientist on the team. And today I'm glad to have you all join me for a great discussion on equity in telehealth. So this year's coronavirus has changed the way we live and the way we work, and it might have also permanently changed the way we interact with our doctors. And this new era of COVID-19 has turned telehealth and telemedicine into the new face of healthcare. So for those who are unfamiliar with the terms telehealth and telemedicine, it's essentially just the remote diagnosis and treatment of patients using video and or audio. So simply using systems like Skype, Zoom, apps on your smartphone, computer, tablet, or maybe just a simple phone call. And in the past few years, telehealth has really was already really on the rise, so to speak. But COVID-19, this pandemic this year, really caused it to explode astronomically. And now that we're finally integrating, with traditional medical providers out of necessity, we're interested in answering the questions: how will AI ensure the long-term success of telehealth and telemedicine? And how do these unique, interesting challenges that we have in improving access to quality care for all patient populations, regardless of race, income, status, occupation, and where their zip code is? So here to answer these questions are our wonderful panelists of doctors, starting with Dr. Alan Young. He's the Chief Medical Officer at Safe Health Systems, and he's an innovation-focused physician with broad experience across management consulting, medical group operations, ambulatory clinics, inpatient surgery, digital health startups, and artificial intelligence. He's passionate about bringing like-minded individuals together in the spirit of health information technology, entrepreneurship, and AI to improve the healthcare experience for patients and physicians. He was originally born and raised in Canada and has worked globally on various healthcare initiatives and medical missions. And he's currently serving as the Chief Medical Officer at Safe Health Systems, where he's building a telemedicine and virtual care platform focused on diagnostic testing from the ground up. And next we have Dr. Elon Shapido. Ilan was born and raised in Mexico City, and he has represented the Mexican Secretary of Health at the World Health Organization, and he has been creating binational programs to improve underserved communities, having the philosophy of using technology as a bridge to include the most vulnerable and advance the wellness at all levels. He has had the honor to be a part of multiple software health-related companies that reflect the objective to improve social determinants of health that go above and beyond traditional methods. Dr. Shapiro is now the Medical Director of Health Education and Wellness for a FQHC system in Southern California. and he's reaching more than 300,000 patients. His life mission is to translate medical-ish, quote unquote, to a universal, actionable language. And last but not least, we have Dr. Stanley Frencher. He is a father, a husband, a Christian, a urologic surgeon, and physician executive, and health services researcher, and also a social justice activist. He's born the son of a primary care physician and nurse educator with 4 siblings who are all service-focused and mission-driven. And he was raised in Detroit, motivated by the social context of that community, which has shaped experiences, or his experiences, in public health, health administration, policy, clinical practice in underserved communities. And he is a catalyst for innovative interventions aimed at achieving justice in healthcare. He's supported by and successful due, and his success is due to amazing mentors and team-based approaches. And in his extracurricular activities, he's an avid powerlifter, a stand-up paddleboarder, and lover of everything active and outdoors, especially involving water. So we have a great group of panelists here, well-versed and diverse, and I'm sure they're going to bring a lot to the topic that we have today. So in the current state of telehealth now, I'm sure most of the listeners here, if you have had any contact with your doctor so far this year because of the pandemic, you may have had at least one telehealth appointment or telemedicine appointment. And unfortunately for many other people in the country, they have not. And that has obstructed their access to healthcare and access to their medical doctors. So we are dealing with huge health disparities currently in this country. And the formal definition for health disparity, for those who are unfamiliar with it, is a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. And this can come in the form of systemic discrimination, possibly through racism and the criminal justice system, whether they have healthcare access or utilization, occupation, education, income, and an individual's housing environment. And telehealth is something that many people have expected to ameliorate some of these issues when it comes to those populations receiving the healthcare that they need. So the opening question I would have for the panelists is, what is your overarching message in how to address health disparities? And if you could provide some perspective on why you're personally invested in solving this problem. And also, before the panelists begin, to the attendees, feel free to type in your questions in the chat, and we will like to include them in our conversation. So Dr. Alan Young, would you like to begin?
Sure. Good evening, everyone. Thank you for attending. I know it's late in the evening for some and later for others, especially those coming from outside of the West Coast, but it's great to be here and being surrounded by these great speakers. I'll just start by saying that, you know, the equity in healthcare because of telemedicine has really shone a light on the areas and the people who traditionally didn't have access to healthcare already. And it's kind of focused the attention on the folks that desperately need it. And I'll start by thinking about urban versus suburban. We can cut it many ways, but for folks that traditionally had to travel long distances to see their doctor or fight, you know, hours of traffic just to see a specialist for 10 minutes, I think the healthcare system may be giving them the opportunity to have these visits through telemedicine without having to, you know, sacrifice the kind of the time and the energy and the money required to do that. However, what it's also doing is creating limited access for those that live away from these city centers or urban centers and don't have the technology to enable this. So the distance is now compounded by the fact that there's limited number of in-person visits, and you have technology barriers with spotty Wi-Fi or overly expensive broadband service, a lack of a number of devices, or even in some cases, the lack of privacy to actually have a conversation with your physician. So the distance to seeing your doctor in some cases has now been reduced because of telemedicine, but for those that can't overcome the distance with technology, that creates an even greater barrier because physicians are now cutting back the number of visits, or because of the pandemic, have limited their access to these patients.
give the amazing opportunity, Dr. Frencher, to actually share his moment, because I think that Dr. Berry is actually having some technical difficulties. But Dr. Frencher, take it away.
Exactly.
From my perspective, just to provide some context, I mean, I think that, Jasmine, accurately talked about the fact that I grew up in the city of Detroit. And I think that I was able to kind of see and experience like a community that was underserved. My father was a primary care doc. He practiced in a community that had largely patients who weren't always able to afford to reach a physician and to certainly have insurance. And that's in kind of an urban underserved area. When I chose to work out here in Los Angeles, my first job has been at Martin Luther King Jr. Community Hospital. I was recruited to help open that new community hospital, where I first was introduced to some telemedicine modalities, like to help engage patients in the form of e-consults. As a specialist, a lot of my research has been focused around increasing access to specialty care, which is particularly challenging, right? Like specialists aren't necessarily, flocking to set up shop in areas that are low income, in areas that are rural, and we have the option to practice closer to larger city centers. So being able to spread the expertise provided by specialists has been a goal of mine and a focus of my practice and the work that I do outside of academia, as well as my entrepreneurial venture. So I think that when thinking about how to resolve the issue of, and I would use the term justice, like as opposed to just equity or disparities. I mean, certainly, counting the number of people who belong to certain ethnic and racial groups that, suffer disproportionately from a particular disease is important, but understanding how we adjust the systems, like, and how we change the way care is delivered is a form of justice, like, and social justice that is required in trying to even the playing field with respect to healthcare. And I focus on system solutions first and foremost. And I think telemedicine provides a way to try to begin evening a playing field so that patients then are not making a choice between taking a day off of work and driving those 60 miles to go see a physician. They're not making the choice between going to an expensive physician visit and paying a copay, as virtual care may be ultimately less expensive and offered by health plans without additional cost to the patient. And then it allows our specialists to reduce their cost to be able to provide care in communities of color and in geographically disparate communities. So I think that when you look at the promise of virtual care, I think those are the potential promises in trying to even the playing field from a systems perspective, like and allowing patients to access care more efficiently, more cost effectively, and allowing providers to be able to provide that care without having to increase the number of specialists overnight in these communities, which is certainly challenging given the limited number of medical schools like that produce physicians who go to practice in these areas. So I think that from my perspective, that's my passion, is how do you bring that expertise to patients? And when we think about virtual care, it extends beyond just video visits and phone visits, but how do you provide a continuum of care that starts even as simple as chats, like these things called e-consults that allow patients to be able to be supported by their primary care doctor more using specialists, all the way to video visits. So I think thinking creatively about how we integrate it into practice is also one way to think about how we begin to address this problem. So those are my insights.
On my side, I was born and raised in Mexico City, and my training was there. I had the pleasure to be involved in since young on social justice project, trying to bridge. One of the interesting things, what's the difference between a gang member and Boy Scouts? Is just the objective. That's it. You need to bring people with an objective to figure out something good, and you will get it. Telehealth is that energy that we had for many years, and especially right now that I have been devoting a lot of my efforts and energy to make sure that health is brought in a good way, in an easy way to the community that actually needs it. Telehealth was marginalized. We were talking about the internet divide. We were talking about like lack of technology. We were talking about many efforts that, you know, they are kind of real, but and there were a headache because nobody wanted even to try to do something new because there were so many barriers that underserved communities or communities of color were not even trying to be on the map for all of these things. And, you know, research like Dr. Young and Dr. That's Frencher, that's kind of the things that push the boundaries and have a different question. Then I still remember when my pediatrician used to come to my house, and I hated the vaccines, and right now I'm a pediatrician too, but I hated the vaccine, but he went to my house. And for the first time in telehealth, I'm able to go inside of the houses, to the private space and quarters of my patients for the first time in my life. I have been practicing pediatrics for more than 12 years, and this is the first time that I understand how my autistic patient actually behaves at home, or how, you know, grandma is taking care of the kids, or, you know, you can actually see a lot of the things that we take for granted when we ask social determinants of health questions, and actually validating it on a visual mode. It's eye-opening. And a lot of the things that I have been seeing in the past, you know, regarding equity and telehealth is that
Breeze there? Okay, let's see. Okay, we'll see if he comes back in a second. But I think he made a very important point there regarding, you know, telehealth allows him to see patients in a more so a monitoring environment. So it's not just the patient setting up an appointment at a specific time during the day, but they may be able to catch an instance at a particular time and see behavioral changes, maybe over the stretch of a few hours, or maybe catch an instance of an episode happening in that time as well. So while he gets ready to come back on, we can discuss to that point, you know, telehealth disparities aren't simply just a matter of a lack of access to computers, phones, or Wi-Fi. What other factors do you think may contribute to patients not receiving quality care through a technical infrastructure, or maybe through infrastructures that may be dealing with policies, or simply lack of education on how to operate some of these devices and software systems?
Sure. I'll give a few examples of where I've seen challenges outside of the technical things. I think one of the things we take for granted sometimes is the communication between a physician and their patient, both verbal and nonverbal. And oftentimes you can't get a sense of someone's body language or other factors that contribute. Where in a two-dimensional space, you can see them, but you can't really understand, you know, their presence. And so even doing, you know, obviously taking away the ability to do a physical exam, but I think the ability to hold a patient's hand or comfort them or recognize what their comfort level is with the physician is something that builds trust. And sometimes I think the trust is harder to establish with some patients, but other patients really do enjoy being comfortable in their own home. And they can avoid some of the distrust or the trepidation that comes with being in a doctor's office, an unfamiliar setting, and, you know, not having the ability to be in control. I think that's another way that patients can feel like, I can always turn off my monitor. I can walk away. I can, you know, mute the physician or mute myself. And that gives them a sense of control, and something that I think many patients relinquish traditionally as they went into a doctor's office. They had to be checked in, they had to wait, they had to be walked into a room, get their vitals. Now you have the ability to maybe with a handheld device, empower patients to do some of the checking of their vitals at home, doing a pulse ox, a temperature, listening to their heart sounds, even doing a single lead EKG, examining a skin mole. They can have a device in their hand to examine themselves. They can also actually get some of the things that they need in advance of seeing the doctor. So traditionally you would go and see your physician and they say, okay, well, I don't know what's going on, but I need some blood work. I need an x-ray. I need some of these diagnostic studies. And that's been another barrier where telehealth can actually maybe expedite getting those done before the visit. So it becomes in replacement of a physical exam, you can actually spend more meaningful time talking about lab values and x-rays and things that you didn't need in the in-office visit, but might have been delayed in those cases.
I think in addressing the question of kind of where like there's still challenges, like you said, I mean, some of them are technical, but I think taking a step back and understanding that telemedicine for both the patient and providers needs to be considered a learned skill that has to be taught, right? I think we take for granted that you give a physician and a patient a new toy to play with from a physician perspective. You give me a new ureteroscope as a urologist. You give us a robot to do surgery, and all of a sudden, that transforms how we deliver care. But that has to be taught, right? And I think that in both for the patient side, like helping them by creating tools that are intuitive, like as intuitive as using WhatsApp or any other type of tool. I think we've overcomplicated many of the construction of some of our applications in telemedicine. Made them in an effort maybe to be more secure and HIPAA compliant. We've made them completely inoperable and not able to actually function with other tools and for patients to use them easily. So I think that's on the tech side. I think once we have the technology and it's in the hands of patients, we need, the gap is in making sure there's people who can guide them through that process. The same way that we have community health workers for guiding patients with cancer diagnosis through a complex system of care. I think you need people who are going to guide patients in the use of these new tools to fundamentally use them well and teach them how to use it. And then I think on the physician side, I think there's a lot to be learned and understood about how physicians are using it. And then and a lot to be done to teach physicians best practices on how to use the technology. Like beyond just kind of the how do you bill for it and how do you get paid for it, but really what conditions should you be using it for? And at what point should we be using different modalities within telemedicine? So what point is it okay to just chat with the patient? What point do we need to escalate that to a phone call or to a visual through a video? And is there a way to teach and understand how to do that systematically with patients? So I think that those are kind of, I think, the gaps that I see.
So at that point, Dr. Frencher, in your experience so far with telemedicine, have there been clear boundaries set on the physician side to disseminate that information to patients to say, hey, if you're experiencing X, Y, and Z symptoms, or maybe this type of symptom here, call me or get on the app, so to speak, and see me visually?
That's the thing. It's not been done. I think it's an opportunity for us to optimize its use, right? It's just not been done or thought of. And some people think we can use AI to kind of help guide patients through a triage process to know where to go. And I think AI is likely a valuable tool in that, in the armamentarium to ultimately solve this issue. But that's a tremendous gap, I think. And I think until we solve that problem, particularly for low-income patients, and those who ultimately are coming from vulnerable populations who maybe don't speak English as a first language, because we also know that a lot of these tools are not bilingual, have not been structured that way. And so I think that are multilingual. I think that is really where we have an opportunity to improve, telehealth and the use of AI for our patients.
Awesome. So Dr. Shapiro, you're now back on. Sorry for that technical difficulty there, but we were just discussing what other factors may contribute to patients not receiving quality care through the technical infrastructure. And maybe you can shed some insight on that.
A lot of the things that I have seen right now in the clinic and the things that we switched our entire system from one day to another, actually in 2 weeks, from completely face-to-face situation to actually video chats and telephone visits, and actually use telehealth the way it's supposed to be done. And we had a beautiful plan for a 2-year span line and everything. Then a lot of the things that we
Now Alan is gone. Let's see.
I think I may be frozen and Alan may be gone, but I could pick up where Dr. Shapiro started to talk a little bit about the lived experience in trying to implement telemedicine very quickly. Mm-hmm. I know at our institution, we were working to implement like telehealth solutions in the midst of COVID, we learned a lot, like, you know, in terms of what works and what doesn't. And I think that one of the biggest challenges we found was, like, number one, getting patients to be able to log on to the tool, like, you know, and download an application, which sounds simple, but for many of our patients was quite complex. Like, you know, even things that we take for granted, like, you know, click on this or instructions like download the app have to be explained in detail. Like, what does download mean, doctor? Like, I mean, like, and literally having MAs spend 15, 20 minutes with a patient to try to get them to understand. Once they've been walked through the process, replicating it was helpful, but that barrier to entry often led to people not using the tool at all, right? So if people aren't having a good initial experience with these things, like, then oftentimes they're like, well, I'll just go to urgent care. I mean, this is just too complicated. So we have to, you know, help people to be able to utilize it even better. And it's just not going to be a technology fix. I think that we really have to empower our staff in our clinics, our MAs and others, to be able to assist patients. And that's what we found in trying to implement certain like telemedicine tools on the fly when COVID occurred. And I think that when you do that, you do miss things. And so one thing that we learned was the need for integration of language like abilities and translation services into our telemedicine tools, right? So if you don't, like, if you haven't thought about it, a lot of these tools are bidirectional between one provider and one patient. Like, but when you need a translator brought into that like conversation, are all of the tools that are available able to create those group chats and be able to leverage like known translator services, like, in order to you know, be able to provide culturally competent and, you know, and bilingual like services to patients, right? And so I think that, you know, the absence of considering and thinking about language in the construction of a lot of these things, like, is itself an example of how we don't consider equity and social justice at the beginning of a lot of the innovations that we go about, because it's truly an opportunity to level the playing field. With technology, we can make sure there's a translator for every language in every interaction that every patient has in telemedicine. Like, we can do it today, but the tools have to support that. So yeah. So Dr. Shapiro's back. So I'll let you.
Thank you. I'm going to make it quick. If not, I'm probably going to disappear again. But that's exactly my point, that we have everything there in place. And the thing is, our communities that are underserved, communities of color, have never had the opportunity to actually experience telehealth. Or these were things that you saw on TV, you heard about it, you saw on YouTube videos, but they were using technology for videos. They were using for SMS, for emails. But ask them, do you have an email? Some of the times they said, I have no idea what's my email. Even though that it was already on their smartphone, and that's something, there's little things that we can start changing the conversation. And for example, right now, from 300,000 patients, right now, I think that we hit 20,000 people that actually are using our electronic My Chart thing, that they can talk to us and send us messages. And it's life-changing to people and diabetic patients, people that have chronic disease, when they understand that they don't need to wait, nothing against anybody, like 400 years on the telephone trying to figure out who they need to talk, or I just need my insulin. And after that, the conversation with the doctor, why your A1C is so high, then with this, levels everything. And it can make a better experience for everybody, for the doctor, for the patient. And I work a lot with promotoras and healthcare educators. And they are loving the platform of digital care because they can do multiple things in multiple places. And the patients at the beginning was a struggle. The curve, the learning curve was hard. But afterwards, they love it. Everybody loves it.
I read one statement on a report of a telehealth platform recently, and it had 17 steps in order for the patient to get through their profile information and set up. And one of the commenters said that's 15 steps too many. So, and we just need to reduce the amount of operations it takes for a patient to log in and see their doctor without making it too confusing. And I think you all are providing great insight to that area there. So some of you all have, especially with Dr. Shapiro and Dr. Young as well, you have worked with companies on the AI and the software side. I'm interested in hearing what are their, maybe from the business aspect or the development aspect, what are their main concerns when you come to them asking about what type of infrastructure should be put in place, or what are their top concerns when they're developing these procedures? I know we just talked about reducing the amount of procedures it takes to hit or to operate an app, but what other aspects are they looking for coming from the health perspective, which you guys bring to the table, that aspect?
Sure. So I'll share two perspectives. One, I think, is important for health systems to acknowledge around as you create these new tools and can gather information, and you still have a burden of responsibility on the physician to document everything, to capture what they're talking about, observe what they see on the telemedicine visit, what they looked at in the electronic health record, and capture kind of the documentation of the history from the patient, reviewing of their medical background, their surgeries, and also thinking through your care plan. So a lot of the AI tools from the health system side, from a business perspective, has been meant to try to make the encounters more efficient, to help physicians with documentation. You see the rise of a conversational AI or chatbots that can ask the questions on behalf of a physician and maybe capture the documentation in a meaningful way. There's ambient voice recognition that can do that as well. And so all these tools are designed, in all honesty, to make the system more cost efficient, see more patients, capture enough documentation to warrant and create medical necessity for a code or billing process. So that's from the business side, and I think AI is proven to serve not only in the care setting, but operationally across non-clinical areas. Robotic process automation is growing immensely across health systems as they try to cut costs during this pandemic period. Unfortunately, it also somewhat impacts, human jobs, because some of the roles and responsibilities can be replicated with an AI. But I want to switch gears and look at how we can use AI to improve the patient experience. I think the scariest part is when I, as a patient, talk to Dr. Frencher or Dr. Shapiro, they may be explaining things to me and telling me all the great things that I should be doing, encouraging me. How do I keep track of that? Am I going to be typing on the keyboard or writing things down, or recording that message so I can go back and play? I think it'd be really transformational to deploy AI in the home setting to give patients the ability to reduce their friction with using these tools. How can they get a care plan? Like if drugs are mentioned and refills are mentioned, can it serve as a reminder? Can the AI create a reminder on behalf of the patient because it knows that that's what Dr. Frencher wants, rather than having the patient set their own alarm or write something down and figure out, does this fit into my lifestyle? Can we deploy tools that extend beyond just a video or asynchronous environment and use the AI to follow up with the patient? Say, hey, did you do these things that were part of your care plan without being intrusive or obstructive to their day-to-day lives? And I think that's where AI has an untapped potential to really help patients in their home setting, the same way we're trying to help doctors overcome the burden of technology.
On my patient part, I do believe that the interaction, we know that at the moment that the patient understands how they need to take their insulin, it's in a language, in a way that they understand, and they can go back and understand what's happening. That's a key factor for asthma. That's a key factor for diabetes. That's a key factor for obesity. The way that we actually treat everything, then AI can actually help us figure out a lot of these things. If we have like sensors on the future, what I would love to do is actually really use food as a company, food as medicine, where you actually can have like your fridge that is intelligent, and it's actually telling you the IA what you're cooking and how you're cooking, and that stuff for a lot of my diabetic patients can make a huge difference on the way that they will perceive food and the interaction as food as medicine movement. That will be like the 3.0 of absolutely everything that we have in front of us. One of the hardest thing that I'm seeing as a system when we're consulting and creating things is that we need a lot of the times we start designing the whole system for the system, and knowing that the system is broken, that's a bad start. Then putting a lot of one of the things that I have tried to do a lot of the times, at the moment that we are designing anything, we bring a patient that is verbal, that we know that has a track record of giving us no, you're wrong, and that way we hear at every stage of the creation of the process feedback of where we have. That way, when we talk about steps or language, or like that button has it's too small, or we started designing a lot of things for elderly patients, for patients that actually need a lot of visual stimuli. Then do we do the big things or the colors or what to match? Then it's a lot of the things that is changing with AI. It's how can actually we can serve the patient to serve the system, because we know right now that in the old days the doctor was here. Right now, AI is here, and the patient is still here, on top of all of us. Then we need to actually continue that cycle, understanding that the patient needs to be on top.
Awesome, great insight. Dr. Frencher, did you have something to add to that?
Yeah, so I mean, in my work, I've been spending the last 3 years in terms of working and implementing telemedicine in underserved communities like the Inland Empire in South Los Angeles, working with IPAs and health plans and health systems. And I think that the thing that I find most challenging and where there's opportunity is not so much in the products that we produce, but in the process that we implement them. So I think that oftentimes you will have a product or a technology solution that one wants to bring to me as a physician executive and say, is this something that would be helpful for your patients in your practice or in your hospital? And the thing that's kind of lost is that it's really about behavior change and integrating that new product into the work that we do. So you have to first understand what problem are you trying to solve, right? And so for us on this panel today, if our goal is to solve the problem of equity, in healthcare delivery, then we're looking for products and for technologies that would ultimately begin to solve issues of social determinants, as Dr. Shapiro aptly put, right? What are things that are going to reduce barrier to entry for patients to access physicians? What are technologies that are going to reduce travel time? What are technologies that are going to reduce the patient's personal cost to accessing care? What is going to make it more easy for them to be able to transport their information from one provider to another, knowing they may be churning off different types of insurances because of the challenges in maintaining longitudinal employment? So I think marrying the products and the technological solutions with the actual problems that are faced by our specific types of patients in in underserved and vulnerable populations is the key, is the key for product development. So we need more of these companies to be thinking about our types of patients in our communities first, right? Because if you can do it in our communities, I feel you probably can apply the same lessons learned across the board, because we have some of the greatest challenges in getting our patients access to care. So that's the perspective I would change. Is not go to where we know we can do this at cost and it's profitable and we can get patients to pay for it, but rather, can we figure out how to fix this problem of access to care in these communities, and then we can apply it to others. So I think that's my perspective when working in developing tools myself, working with our companies at Wise and Hub and Afia, but more importantly, when approached by others who are developing tools, that's usually where I start, is what problem are we trying to solve, so that we can ultimately apply the tools appropriately.
All right.
And if I may, Jasmine, just mentioning something that Dr. Frencher actually stuck to my brain, it's the human design part of it. It's key factor of this. And one of the things that, my challenge to a lot of the big tech companies is that until it actually gets to the communities of color, underserved communities, it takes a while. It needs to be standardized. And the other thing is that, if we're seeing the big picture of healthcare and the things that we have in front of us, the best ROI that we have as a society is to make sure that this type of services are actually low cost and big volume that actually be applied to communities to make a huge difference. And I think that it will pay by itself instead of, suffering diabetes, suffering obesity, suffering asthma, or so many other things that can be already solved. And right now, COVID showed us with algorithms that AI can actually play a huge role on education and actually patient management. Then, we need to use it.
Absolutely. I totally agree with that there. And we're winding down to the last few minutes of our panel. So I'm going to possibly get in a few questions here. So the first is, what do you think about the lack of standard digital medical records in the United States? And let's see here.
Yeah. I mean, I'm happy to jump. I mean, I don't think anyone on this panel would disagree that, the lack of having health information exchanges, the lack of being able to access the records of our patients who go to multiple facilities oftentimes, particularly in our community, right? So I practice in South Los Angeles, and it is frustrating that, ultimately, despite the fact that we have a robust EHR, electronic health record, I often resort to calling physician offices to fax me information when their patients are admitted to the hospital. I mean, it's unconscionable. And this is 10 to 15 years hence we started discussions about interoperability, and we're still struggling to get there. Now, when it comes to the use of telemedicine and AI tools, I think that one opportunity is to disrupt all of that by empowering the patient to be able to own their medical records, right? And be able to ultimately have control over, their dialogues and interactions and information being shared with them. They'll have it. And I think that the more that we can empower them to have it, the less we're going to rely on the information, often erroneous, that's contained in some of our EHRs.
Okay, thank you. Next question. What are the challenges that doctors face when integrating products into their practice?
Let me take you that one. Oh my God, it's like trying to put a tooth in a tooth that is already there. It's hard. You know that there's a function to it. You know that you need to chew with it, but sometimes it doesn't fit. Then the first question, even though that, and this I prefer to be lean and mean, meaning that there's a lot of toys out there, and you don't want to have so many toys that you cannot actually use all of those. Then you need to make sure that as a provider, you understand the mission and the objective of what you're looking for. What's the ROI could be money, the ROI could be just patient satisfaction, or the ROI could be your MA or staff satisfaction. That counts a lot too. Then what's your ROI and how much you're willing to invest? And the other thing is, what's your escape route? Because we have heard, epic EHR horrible stories, and that's the big thing that we have right now. But the same thing with imaging machines, with other stuff. Then find your objective, find what's your real ROI, how much you're willing to invest, and what's your exit strategy. Then that would be the 4 things that I would consider before implementing anything.
Okay, and the last question for the night is, once a potential solution has been found, what do you think are the initial steps needed to implement in your respective scenarios/environments?
Sure, I'll take a crack. So one of the potential scenarios is to really leverage AI technology to get diagnostic tests out into the community at a low cost and allow physicians to respond to the results of these tests quickly, without having patients to go in to see a doctor, get an order, go and get the lab test done, and then come back, or pay unnecessary costs related to the overhead of the clinic visit. Imagine if these tests could be done remotely via your telemedicine counter or an automated system. But the way to deploy that is that you have to get buy-in and realize that it fundamentally changes the reimbursement model and the fee-for-service model, where, okay, well, we had this patient came in and they thought they had a UTI or strep or COVID, but we get to bill because they had physician time, they came into a clinic or a hospital, we did some other stuff. But in reality, they just got a positive test or a negative test, and then that reassured them or dictated what their care plan was. And we see this in flu season coming up. People are coming in getting a rapid flu. If it's flu, they get the medication. If they don't get flu, they're told it's probably an upper respiratory infection, viral, home health, all that good stuff. So I think it requires kind of this change in mindset that this is for better outcomes for patients, creates maybe better efficiency in the primary care setting by decompressing clinics where a lot of patients are coming in for these rapid tests and taking up an entire visit just for the physician to say, yep, your test is positive, here's your antibiotic, thank you for coming in. I think we need to pilot these kind of solutions in kind of the high impact areas and see if they make a noticeable difference for physician satisfaction, patient satisfaction, and overall kind of business or financial, solvency of the practice.
Great. We have just hit a few minutes past 6 o'clock. So if the panelists have any last or parting words that you would like to share, now would be a great time to do so. And we'll wrap up so that the attendees can go to the next session.
I think the only thing that I would want to leave you guys with is that I think far too common, historically with innovations in technology, it comes to our communities of color and vulnerable populations last. And I think that, leveraging like Wi-Fi as opposed to setting up telephone lines is a way to leapfrog poorly established infrastructures. And I think from a virtual care perspective, it may be similar, meaning that why go around building more brick and mortar hospitals, clinics, doctor's offices, ambulatory surgery centers, when in fact, we may be able to consolidate the needed care that patients have in person, make that very high value, high intensity when it needs to happen, and everything else managed appropriately and right sized to exactly what patients need and no more. So if they only need to chat with me because they need a refill, that's what happens, as opposed to them driving 60 miles to get that refill. I mean, it sounds simple, but I think that really that's going to be the change that's necessary in our communities where equity is an issue.
I really want to thank everybody that actually heard crazy stuff with technology and without technology. We need to remember that COVID has taught us a couple of things, that a lot of big enterprises are going out of business and a lot of them are coming in. But the excuse that we had to actually serve underserved communities with telehealth is gone. We are seeing right now the importance for that. We're seeing actually how lives are being changed, because we're hearing and saying to all our patients, stay at home. Let me at least try to crack this before you come to the clinic, and it's working. Then the concept is already proven. Right now we have the codes, we have a lot of policy to go. Of course, we already talked about what's the best way, or what's the protocol, do we start with this or that? But we need to understand that the reality is here. Telehealth is here to stay, and I agree completely from this panel that we need to start designing from our underserved communities up, or at least integrate to the part of protocols of research and artificial intelligence and all that things, because I promise you that algorithm that will throw an AI from a Beverly Hills zip code to the zip code that I serve in East LA or the South Side, the answers will be completely different. Interact with the AI at the beginning. Then at the moment that we start at the beginning to actually teach all this information in an equity way, and it's inclusive, and it's in our language for our community, I think that we're going to be advancing.
And all I have to say is, great hearing all the perspectives from the panelists. Again, representation on this panel has been amazing. It's inspiring to hear kind of the perspectives everyone brings. But, I do think in the midst of this telehealth revolution, the artificial intelligence revolution is coming. It's kind of creeping as the second wave. Not a lot of attention has been paid to it because, there's not enough time to think about these new innovations when you're struggling to keep the lights on with COVID, wreaking havoc across the world. But the artificial intelligence movement is definitely a groundswell, and it's happening as well. It'll be following right behind the telehealth movement, I think.
So that wraps everything up. Thank you, Dr. Frencher, Dr. Young, and Dr. Shapiro. And thank you, attendees, for joining us tonight. Feel free to transition to the next segment starting now.
Thanks, everybody.
Thank you all.
Night.
Good night.